Well, I got to address Erica's first. All right. Probably the biggest obstacle to effective non-invasive ventilation is getting the right interface. Who was Casey? Was it you that said your husband was on?
My dad.
Your dad on CPAP? And typically, the first interface they try doesn't work really well. It's about the fourth or fifth one they finally get around to getting the interface correct. This line here you can now scratch off, most common interface. It's probably, even in the home, being replaced by a full face mask as the primary mechanism for ventilation. For years it was the most common interface, it's just a mask around the nose itself. But more and more we're looking at doing a full face mask in the hospital for sure, but even in the home.
A lot of mouth breathers out there.
I'm sorry?
A lot of mouth breathers out there.
Yeah, that's part of it, and it's just much more easy to fit and easier to use is a full face mask. But basically you have a cushion that goes around the nose. There's always a desire to have a small leak because otherwise you get it too tight. But in this case, we want it to be going in a downward fashion. You always want any leaks to be directed away from the eyes. So we don't want it blowing up into the eyes. We'd rather have it blowing downward. There is a guide, and there is some head strap. And the foam bridges are used more for a, what's the word I want to use here? For a frontal plane, in other words, this way, up and down, as opposed to side to side. It's going to be pulling the mask away from the bridge of the nose, and you'll see when you see a picture of them. Full face mask surrounds both the mouth and the nose, and we always want to have some kind of a quick release mechanism, so if they begin to vomit, that the mask can come off quickly. Obviously, you don't want to have the blowing chunks back inward. Here's the nasal mask. You can see it goes from the bridge of the nose to around the lip. I'm sorry, that would be a full face mask, wouldn't it? Not a nasal mask. The nasal mask would just go around, and there's a ring that we have in the lab for the Respironics masks that you can go ahead and measure the size. And one of the things we will want you to do is to know how to size a nasal mask and a full face mask, both. And this is the key points when you're looking at a nasal mask. The bridge of the nose, the sides of the nose, and the upper lip are the points at which pressure points typically are needed to cover with the mask. And here you can see the mask with the face plate and the cushion that is there. And then there's usually a support rings that goes around the bottom portion of the cushion, so the cushion doesn't displace outward. They just give you a little bit more of a support. Just another example of another type of mask that has a comfort flap, which is a second piece of plastic that goes on to give you even a little bit more support that is there. And basically what ends up happening is as the mask pressurizes, it actually pressurizes inside that flap there too, so it gives a little bit better seal in the process. And these are the spacers that are utilized. They take pressure off the bridge of the nose, and there's a sizing guide that you can kind of get an idea of how much pull you need to have there. And there's an example of how they're used. They're slid onto the mask itself. So this basically is against the right above the bridge of the nose along the forehead. You can see it there. So it's displacing the mask in that plane. If the mask is too tight, again, we don't want to have no leak. We want to have some degree of leak. Nancy, was it 20 to 40? Was that what?
40 to 40.
Liters per minute of leak?
I thought it was 7 to 25.
7 to 25?
Yeah, for patient leak.
Yeah, the number didn't sound right to me, but okay. And then if there is a rash that develops, you want to make sure they're not having an allergy to the material itself or that spacer. But there's some microfoam tape you can use to have it so it's not in direct contact with the face. And then the last part of this is a headgear, and this will be the fun point. You'll go ahead and place these on each other. But basically, there's 4 straps that are present, and they go into there's 4 clips on the mask itself, 2 here, one on each side along the nose part. So we've got another picture of it here. I don't think I do, though. No. Okay. But that's the headgear. And basically what you're doing is you're trying to get this, when you're putting this on the patient, you'll go ahead and put these on very loosely until you can slide it over their head, and then go ahead and adjust the top straps first so they're above the patient's ears, and then go ahead and do the bottom straps after that point in time. And then there's a strap that goes across the crown to this portion here. Come here, you. Where's my pen? Oh, help have a plate. Well, whatever. So here's the crown strap that basically is also pulling tension along the back part. So top strap, neck strap, and then the crown can be adjusted also. And then we're going to go ahead then and tighten these once it's on the person's head. Go away. And that's what we just talked about. Okay? And you'll get a feel for this. When you got an inadvertent leak present, a good tip to keep in mind, always adjust the strap that is opposite to the leak. So if I have a leak around the upper lip, or the chin in the case of a full face mask, the upper strap is too tight, and if you loosen that a little bit, you'll end up having it. So if I have a leak down here, it's because this one is pulling too tightly, and loosening it will put it more in line. And the opposite is true. If it's leaking around the eyes, loosen the bottom strap. Somebody who does happen to have a nasal mask and has their mouth open during sleep, there actually is a strap you can get to hold their chin up. Like I say, most of them are face masks. This is just another type of mask that has a gel formed so that it doesn't put as much pressure on the top of their head. The expiratory gas has to exit the mask in some fashion, and that's what the purpose of that whisper swivel or other types of exhalation valves that you'll end up having on non-invasive units. More often than not, though, we're using a full face mask, which will go around just like a resuscitation mask, held in place again by the 4 straps. And this one has, these are easy to disconnect also, so that you don't have a situation where they're vomiting. And then there's the total face mask, also known as the, yes, Steve?
So the whisper swivels, it's a really small port. How do they exhale?
It goes back out through there. I know it doesn't seem, logic would say, geez, that's not enough to exhale a tidal volume, but it does. Remember too, you have a flush of gas that's coming through the circuitry that also helps push it out too. So, also known as the Jason mask or the goalie mask, because it's what it looks like. No other way to put it. This you would think would be just obnoxious, but a lot of patients prefer this to this. Part of the problem is if you got glasses, this is right here. So it's easier to have a little bit better vision with this full face mask present, yeah.
What about that going into the patient's eyes, though?
Doesn't seem to be as much of a problem. Have you seen it? Nee?
I have it, they love it. You can try it on, we have it, so you can test it
I
out
will.
yourself.
I will try it on.
It's more like the gas is not solely directed at the eye. If I have a leak, it's always pushing there. This way, it's covering the whole face, and you don't get the complaint. Like Dan said, most patients actually enjoy it. Well, I don't know if I'll use the word enjoy, but prefer it.
You know, it's such a life-altering change for some of these people that they really do love it. You know, from where they were with really bad sleep apnea, and they had no life because they're falling asleep 3/4 of their day, to having this therapy now, and they actually are living their life, they do love it.
Yeah.
They don't know what they did prior to it, so.
And even in the ER, it's a whole lot easier to utilize one of these as opposed to just a regular mask to ventilate them.
How does it stay on the face?
There's straps that go around the back too. And then there's some other hybrids that are out there. Believe me, these manufacturers are coming out with new ideas all the time on better ways to be able to ventilate patients non-invasively. Alternatively, there's nasal pillows as a third method beside nasal mask, full face mask. Well, fourth method. And these just are little prongs that you size and place into the apparatus has a little nasal prong there, and they literally just fit into the nares and are able to apply some pressure.
A lot of people, I have to tell you personally, I wear one of these now. I have really bad migraines, and
Did it help?
yes, it
Wow.
did. I couldn't figure out, probably too much information, but I've had migraines for a gazillion years, and went to a neurologist, and he tells me, open my mouth, and, you know, we just learned about the Mallampati score. He opens my mouth and he says, you know, you have a 3 to 4 Mallampati, and I go, I do not. He says, yes, you do. And I went home and I looked in the mirror and go, holy crap, I do. And I've been intubated before for a prior surgery, and they never said I had a difficult airway or anything. Then he sent me up for your sleep study, and I ended up finding out I had sleep apnea.
And your father was a CRNA to boot.
Right, right. And my husband snores to beat the band, and he never complained about my snoring, which I don't snore, and my sleep apnea scores were very low, so it was very, so he sent me for a sleep apnea, like I said, I ended up with a,
And the migraines have
yeah, and I
Pretty
went
resolved?
and got a CPAP machine, and I'm very, very low on my CPAP, but I wear these nasal pillows, and
Do you use pillows? Yeah.
I do, and my migraines have, plus medication and stuff, but my migraines have decreased significantly. And it's working, and I thought it was a bunch of hooey, but hey, anything that makes me happier, I'm all for it stuff.
Yeah, it's not the sexiest looking thing.
I've been married for over 30 years, so I don't worry about that looking, you know.
Dan's sleeping anyway, so he doesn't know.
Nothing wakes that guy up, so I'm not worried about that.
All right, some other considerations that you might have, just a claustrophobic, and again, ironically, the larger the mask, the less the claustrophobia ends up happening. So, when you guys try it on, you will say, I can't understand how anybody could possibly wear this for more than 30 seconds, but patients do. So, changes in somebody's face, you'd be surprised looking at somebody. You think they're this kind of a nasal mask, and it turns out to be they're totally different. And then there's obviously some sensitivity issues that are there, and even the wide nose they've been able to fix with different style masks. Looking at pressure points, and you'll notice in the morning when the mask comes off, if there are specific spots of redness, that's probably something where we didn't quite have that strap adjusted right. Again, morning dry eyes is more associated with a nasal mask that's not properly fitted and attached. Same as, well, the nasal drying was where the humidification might come in handy. And the rest are pretty obvious as far as challenges that are there. But again, looking at it from a full face standpoint, the 4 pressure points or 4 points that you want to have a decent seal on, because it'll have leaks otherwise. Too big of a leak. Most of the stuff, if it's not a single patient use, which in the case of ours is, but they can go ahead and at home soak it in a mild soap solution, or if they do have, and you can disinfect it with a high-level disinfectant that are there. All right, initial settings. EPAP should always be at least 4, if not a little bit higher. And its typical starting point is 5/10. We're always going to use the spontaneous timed alarm, spontaneous timed mode, and it will set our alarms as appropriate. So let me go through the different alarms, just because I know I'm going to forget this. All right. We said there was a high and low pressure alarm, and those are, it's called 2 to 5 centimeters of water above and below the IPAP level. Make sure you're using the IPAP, not the EPAP.
So on the other one is 3 to 5, and this one is 2 to 5?
Did I say 3 to 5 earlier?
Yeah.
Then let's go with 3 to 5, just so I'm not contradicting myself. Rate. I don't mention the rate here, but the rate should be set at something 8 to 10? 8 to 10. Again, it's not designed to be life-sustaining, but if they do have a period of apnea, you want some backup there. Yeah, Dana.
So the rate alarm, all it does is
Hold.
just...
I didn't mention the rate alarm. That's what I'm talking about
so
next.
it's not,
That's the rate itself.
Oh, okay.
The rate itself should be set at 8 to 10. The high rate, I'm sorry, the low rate. It's a low rate alarm. We're going to set as 2 above where that is set. So wherever I set my rate alarm, my low rate is going to be set 2 above that. So I had alarms before it actually kicks in. You want me to say that again?
Yeah.
I set my rate at 10, okay? Meaning that if the patient goes apneic, they'll at least have a transition between IPAP and EPAP 10 times per minute. The alarm, though, I want to trigger before that happens. So if the rate that is counted on the machine gets to 12 or less, it will alarm, and at 10, it'll actually kick in. Okay? Any volume alarm is always going to be 10 to 20% of what the measured value is. So if I have a tidal volume of 500, my low tidal volume alarm should be somewhere around 450. Is that 10%? To 400. So 400 to 450 milliliters should be my low tidal volume. All I did is I multiplied my 500 milliliter tidal volume by 0.9 and 0.8. So as long as it's in that range. If you want to put it at 430, that's ducky. Yes, Dana.
And why do you set like a minute ventilation? Like, you can set it...
Typically, we end up having both a tidal volume and a minute volume measurement. So we're going to have a tidal volume and a minute volume alarm.
Okay. So,
And those are both low in that
Okay.
case. Some of the adult ventilators will have a high tidal volume and a high minute volume. On these, I believe they're just low. Which one am I missing? Oh, apnea. Same for the minute volume, 10 to 20%. Any volume. Apnea should be set at 20 seconds. And the delay for the low pressure should be 15 to 20 seconds. Yeah. think that's all of them.
I think that's V60 might have.
Delay. The low pressure alarm, you don't want it to sound, the alarm to sound every time that low pressure is violated, because it may just be that they're adjusting their mask. So we have to have a sustained low pressure for more than 15 to 20 seconds before that alarm will sound. Dana.
They do have like a high rate for the rate that you can set on there as well. So
Oh, thank you. Yeah, that should be set at 30 to 35? Thank you for a high rate.
Or 20 over their norm.
Or 20 over their norm.
High rate is their patient's high respiratory rate.
So, because again, it's, if somebody's breathing 40 times a minute, you would like to know about it. That's usually a sign of something going bad. You can read all that, right? Yes, Miss Liz.
Would you also want the alarm delay for the rate?
No, it's just for the pressure. That delay is specific for the low pressure alarm. They don't give you an option for any of the other ones, yeah.
See 20 of both patients normal?
Yeah, which should be somewhere in the 30 to 35 range. Nah. 15 to 20 above.
Yeah, they're normal. Patient's normal.
They're
Breathing 10,
normal.
25, 30.
So you can see with this, you need to establish the ventilation, let them ventilate for a period of time, and then set your alarms once you get some sort of stable numbers. And then we're going to go ahead and make changes based upon blood gases or pulse oximetry. So changing my EPAP level for my oxygenation, changing, and by extension, changing the IPAP to keep the delta the same, or if I do need to do both, having the IPAP be increased at a greater level than the EPAP was. And there's a whole bunch of sample questions that are at the end of the module to go through that. Okay, I got my work cut out for me. That change it. This is what we just talked about. So basically then you need to say at what point is this not working anymore? If I have a situation where I have a severe respiratory acidosis, you're not going to correct it with non-invasive ventilation. If their PCO2 is continuing to climb, they need to be intubated and ventilated. Patients who don't have good level of consciousness, especially if I'm using a full face mask and they're prone to potentially vomiting, you don't want to have a situation here. A lot of the elderly aren't as compliant for one, and you may have difficulty with patients who are more profoundly hypoxemic when they first start. Probably are going to be harder to manage with non-invasive because we've already lost part of the time there. And same is true for somebody who is profoundly tachypnic. Might not do well on non-invasive. All right. I don't think that page number is correct, but now you can go ahead and do Lab 10 in your lab manual, and that basically is one where you'll work in groups of 2 or 3, going through the sizing of a nasal, sizing of a full face mask, and then going ahead and selecting it. Starting off, my recommendation is start off on a CPAP of 4 or 5, and then try the the STD mode. I wouldn't go any higher than 10 over 5 initially.
If I can make a suggestion, when you're doing this on yourselves or clinically, is when you're offering it to your fellow student or a patient, is just have them hold it to the patient's face instead of initially strapping it on and Rick already had, talked about it earlier, it's far easier to sedate somebody and stick an endo tube down them and stick them on a ventilator, as opposed to trying to talk somebody into doing diaphragm. Usually it's a half hour, 45 minutes you're spending with the patient to talk them into this, but the advantages of doing BiCAP over intubation are great. But that said, it's a process to get the patient to be compliant with this whole BiCAP thing. But just having you guys stick it to your face without a CPAP before, and then advancing it to see what it is with the BiCAP and stuff, is gonna take a process. But just holding the mask to your face and
You get-
then strapping it
Yeah.
on is how we talk our patients into it and getting more compliance out of them, as opposed to just, strapping them down. And that's it too, we never strap our patients down. If they need to be restrained, BiPAP is not the mode of therapy for them, because they have to be able to hold the
Grab
mask
the
in
mask.
their face.
If you take a look at the PE, one of the things that we will have you, or that you will have to do is position the mask and strap into place correctly. And if we say something along the lines, you got a leak around your eyes, which strap do you adjust, that kind of a thing would be very good. Something else I was gonna say.
But I strongly encourage all of you to try it on yourselves. All of the masks are clean and sterilized. They're not in bags any longer, but they're all clean and have been sterilized. Okay, so use them, and just when you're done, throw them in the sink, and I really. Yeah, really?
So Rick, for the PE, you give us all the settings that you want us to do and all
Yeah,
that stuff, right?
we will go ahead and say, put the patient on 12/6, and then you'll set up all the other parameters. And then when you get that set up, all your alarms are set up, we'll come by, check it out, and then we'll say, okay, here's your blood gas, what do you want to do? And then you'll make those changes, reset your alarms, because you're going to have to regroup them, and call us back over.
For this PE, are we doing like the full, hi, my name is Melanie from Respiratory Therapy Department?
Hi, my name is Melanie, I'm from Respiratory. And you do that now,
Right.
and Liz will let me know if you're not doing it.
What are the chances Bill was taking in a NASCAR race?
Hi. Thank God. All right, questions on what's going on then for the balance of the day? Practice interfaces.
I don't know when I did that, but that's.
Go ahead and put again, your partners on, and then if you still want to practice with the other ventilators, they're there also. Okay? And on tomorrow then we'll start into module F.
Are we just doing F tomorrow?
F and G.
F and G.
F and G.
But
Just sounds wrong.
the quiz is just on E, like, up to F.
Up, not including F.
It's not including.
No.
Oh, I thought.
What does it say there? What does it say in your thing?
Oh, for the studies by just up to.
Yeah, just bypass it. IPAP, EPAP,